So, Dr. Murdy is internal medicine and geriatrics from Baylor Scott White, and today he's going to be talking on COVID-19 and how it impacts seniors, particularly in the Lake Travis area. Dr. Murdy enjoys helping his patients solve complex diagnostic and medical management problems and working with them to get the most out of life. In his spare time, he enjoys boating, flying, reading, and spending time with his wife and 4 sons. How many grandchildren do you have, Dr. Murdy?
Just one. Gorgeous son. Gorgeous video. And we are very desperate to see the child again, but obviously we have to be a little careful about that in light of the COVID issues. When I originally accepted this talk, I was thinking, well, we would talk about primary care and how to best use your primary care providers. And yes, we will address that, but the world has changed in the last 2 months in ways that I don't believe anyone had anticipated. I was looking at a magazine article on what would the next recession look like, and no one really had any good ideas on February 22nd. Yet here we are, not even 2 months later, in a very difficult and different time than we had anticipated. And if you say, well, what is the particular focus, is that COVID-19 is now the leading cause of death in the United States. More than heart disease, more than cancer, at more than 2,000 people dying a day. And that is with all of the efforts that our public leaders and medical community have put forth to try to mitigate this risk. It could have obviously been much worse, but it is bad enough as it is, and we're going to talk a little bit about what that is. I first wanted to touch on who I am. I'm an internist and geriatrician. Internists are doctors for adults. I'm a member of the American College of Physicians and a fellow of the American College of Physicians. Just means that I must have gotten old enough. But also I've been involved as a teaching physician for a long time. My background was college education at the University of Chicago. I followed with the first 2 years of medical school there and a master's in business administration focused on hospital administration from what's now called the Booth School of Business at the University of Chicago, before I went to finish medical school in primary care at Brown University in Providence, Rhode Island, and did a 3-year residency in internal medicine, in ambulatory internal medicine at the Rhode Island Hospital. After that, I practiced for 31 years in the same practice in southern Wisconsin, a wonderful community called Janesville, where for many years we made suburban cars for Chevrolet and Parker pens, and I still have my Parker pens with me today. The point was that eventually it was time to move, and we moved to an area where my wife's family is and away from the cold and snowy north, so we don't have to shovel sunshine here in the Lakeway area. So I'm pleased to be here. It has been a wonderful adjustment. It was hard to leave all of my wonderful patients in Wisconsin. I still have contact with any number of them, many of them through video visits, by the way. But it is wonderful to be practicing here at Baylor Scott White. The poster behind me touches on what are the core principal beliefs of the university, or of the Baylor Scott White, what its strategies are, what its mission is, what its ambition, what its values are. And every physician in Baylor Scott White is asked to personalize that. And mine is to commit to provide the best possible care that patients and members can feel the healing presence of God and enjoy their life to the fullest. And that's what is on my name tag, and that's what we try to do each day here. Also, I want to point out that I'm not alone here. Baylor Scott White's primary care clinic here on Route 620 has 9-10 providers, including pediatrics, family medicine, internal medicine. We're also expanding and opening a clinic soon in the Bee Cave area to address people's needs. And we're very happy to have a wide spectrum of very talented people who can make this a team effort, because this is not best done only one-on-one with a primary care physician, but by having a team, it means that you have more access to more care, let alone the fact that we are connected to the hospital here, where we have a wide variety of specialists, as well as the Baylor Scott White Network in Round Rock and Temple and elsewhere that can provide the type of care that meets every standard within the world. We also want to point out that we are prepared for this pandemic. This is not something that caught our leadership off guard. There are plans in place. Some of that will be described tomorrow. by Dr. Ghassan Salman, one of my partners here in this practice, who's the Associate Medical Director for this region, and Philippe, the President of the hospital, to specifically address how the hospital is coping with and ready to deal with COVID-19. I'm not going to talk about individual patients who are obviously been troubled by this illness, but you can take my word for it that we are prepared and we know what we're doing. But I wanted to talk for a second. Are there any questions about that or my background? Natalie? Great. So what is COVID-19? So obviously there's been a ton of press. I'm not going to belabor it. It is a virus initially identified in China, then moved across the world, particularly the first outbreak outside of China was in the countries nearby, South Korea to Singapore, et cetera. But the first one in the Western world was in Italy. And I wanted to point out that that was thought to be due to a particular contact of someone who had come from Munich to a soccer game, a match between Bergamo and a team from Spain, which led to an enormous outburst of activity in that region of Italy, now generalized across the world. And so you began to see public health efforts to try to address this illness beginning then. But this virus is a coronavirus, and the word virus, if you go back to its Latin origin, is poison, and it often referred to in the medical literature a few hundred years ago as a secretion from people. We now know that they are little particles that can get in cells and replicate, which is how they do damage to us. And obviously we've had them forever. Coronaviruses are of a family that are common cold viruses. A number of those attack everyone every year, but this particular virus is novel, meaning we have not seen it. It is newly transmitted, we believe, and there's disputes as to how new, from bats to other animals to people, particularly in that community in China of 11 million. And now it's been spread across the world. We would think and say, well, what about another cold virus? How could it hurt us? Well, if we have no immunity to it, if we have never been exposed to it, our bodies have no ability to fend it off except through the normal machinery that we have been given to help identify and create immunoglobulins within ourselves. But that machinery takes time, and that we'll go into when we're talking about how the disease develops and how people ultimately recover from this illness. But the point of why is it so bad is that it is a fairly virulent disease in the sense that it causes a lot of morbidity and mortality. And in comparison with other illnesses, if you think about it, it spreads rapidly. To put this into perspective, our chief medical officer, Dr. Watson, showed us a slide in one of our training discussions a few weeks ago that specifically addressed the fact that we've had other viruses that have been worse. As an example, SARS is a little worse. MERS was a little worse. Ebola, a hemorrhagic fever that is most commonly associated with Africa, is worse in the sense that it kills more people who had it affects. But the problem with this is that it is new and it spreads more rapidly. As an example, the common influenza virus, influenza A and B, and this season was a pretty typical influenza season until recently where it pretty much kind of died out, spreads to about 1 to 1.3 people for every sick person. And there was 55 million Americans who had influenza this year, of which I believe 50,000 died. So think about that ratio. But comparison to other diseases, measles is far more transmissible. 15 people get measles for every contact. For chickenpox, it's about 8. Now, granted, both of those diseases, although possibly fatal, are rarely fatal now because of immunizations. And many of our patients in my age and above had chickenpox and hence have some preserved immunity from it, even if we are at risk for reactivation of that virus, which is a disease we call shingles or zoster. But that gives you a little bit of an idea of why is it so bad. The current estimate within our organization's leadership for the death rate is around 4%. I believe that's a World Health Organization number. And if you look at the data, part of that is hard to interpret because it depends upon how many people we actually believe actually have had the disease. And because of limited testing capacity, most of the people who have been tested have had significant symptoms. And so it's hard, except for rare circumstances where some research has been done, to know how many people have had the disease but not necessarily manifested severe symptoms. The purpose of how to understand that is that it's spread from person to person, and obviously that means that you generally have to have close contact. Close contact in this medical definition is that you are exposed within 6 feet of someone who has the disease for about 10 minutes. So casual contact, although possible, is not thought of as a major transmitter, but that is the definition of what we mean by close contact. But it's spread by droplets from speaking, like I am now, or coughing, or sneezing, all of which are part of the symptom complex that can affect people who have COVID. And if we also can come in contact with surfaces, whether it be the counter that someone's standing at, or whatever we are handed, not so much on fabrics, but clearly on cardboard for about a day, on plastic and metal for a day or 2 or 3. And again, there's differences of opinion about how long this can even stay in the air. Some people say that it dissipates within 3 feet. That's why some World Health Organization people say 3 feet's appropriate distance. Other people say that it's been transmitted up to 23 feet. So obviously there's a bell curve for most of these types of things, and we have to take that in consideration when we're thinking about it. What does COVID do to people? So it causes a lot of different symptoms, and we're learning more of what that symptom presentation is like, but it tends to cause a cough and mostly severe shortness of breath. And that shortness of breath is often manifested by very low oxygen levels when it's tested in someone's finger with an oximeter, or in the hospital, or in the lab, or in the clinic if we tested it here. And that degree of low oxygen, that shortness of breath caused by low oxygen, is out of proportion to what we could identify with a stethoscope, or even sometimes the plain x-ray. And the best diagnostic test that we're using right now is actually CT of the chest, if we're in that case of trying to define someone with severe illness. The symptoms often can generalize to fatigue, back pain, body and muscle aches. A lot of the reports that we've seen even this weekend from notable celebrities who've had it is that they realize that this is more than the usual influenza symptoms, which can obviously be bad enough. And that part of what we're dealing with is not only the symptoms, which can include GI symptoms and diarrhea in some cases, but how contagious it is. And we now realize that it takes about an average of 5 days for someone who's been exposed to enough to then have symptoms. But they've often been contagious for a day or 2 or 3 before they manifest symptoms. And in that case, then they are able to spread the symptoms even before they know they're ill, which is partly why, you know, we're wearing masks here in the office. That's my mask for the office. And we have good protective equipment here to try to protect ourselves and make sure that we're not spreading any illness to one another or to anyone who comes here to our clinic, but also that we're trying to make sure that people are aware of the benefits of that if they have a question, and to realize that there's a fair percentage, maybe 20% of people who contract this virus who have no symptoms whatsoever. And because of that, are at great risk. And many of them are younger people. And hence, one of the reasons why I think with wisdom, the schools were closed and people were sent home to do virtual schooling. Part of the other issue that this is so severe is that it causes significant complications. We mentioned that shortness of breath, and that's the principal symptom that patients are seen in the emergency room. And in that case, many patients need to be hospitalized or given oxygen therapy potentially at home, but right now mostly in the hospital. And obviously some come to the point where they need forms of life support. We call those ventilators to help them. Within that, there are some people who pass from this disease. I mentioned that the estimated death rate has varied from as low as 1% in some estimates to 4%, which I believe is the current World Health Organization number. That's the number that we're anticipating it being, but again, the death rate seems to be clustered in patients who are older and who have comorbid conditions, be it heart disease, lung disease, or immunosuppressant diseases where they may be taking medications for cancer or medications for rheumatologic diseases that suppress their immunity as a part of helping them stay well from their underlying disease. Those patients obviously are at greater risk for this virus running amok and causing further complications that they may have a hard time coping with. the way the doctors talk about what we often see in the intensive care unit is called adult respiratory distress syndrome, and syndrome initially identified in the Civil War, often thought about in the Vietnam War where we had better diagnostic care, but it is associated with multi-system organ failure. So not only do people have bad bilateral pneumonias, but they also have bilateral pneumonias in some cases with kidney failure or liver failure, or in this case, even heart failure. And they can present with any one of these symptoms as a potential first symptom, and then go on after the immunological process has gone on to potentially have what we call a cytokine storm. Cytokines are chemicals released in our body as a marker and a cause of fever, as an example, among other things. But those cytokines in some cases can cause our own body to attack our lungs and cause our lungs or other organs to fail. And that's been under research now as a principal cause of fatality in this illness. We also know that there are people doing research now to determine if there are other potential modalities. Does this virus affect our body's ability to carry oxygen? And does it affect, in essence, the hemoglobin in our red blood cells? In so doing, does it essentially manifest more than just as a pneumonia, as something that can lower our oxygen causing capacity and help people feel like they're suffocating? And there are patient reports of feeling like they were buried alive, a very horrifying experience. That's a little bit about it. Are there questions specifically about the virus and what it is?
We do have a couple chat questions, Dr. Murdy.
Yeah, well.
The first one is from Pamela, and she asked, how many people have been hospitalized and how many have died in the Lake Travis area?
Well, I actually pulled out some of that data from this morning. If I'm reading the numbers correctly, I can be obviously off a bit. The number that have been hospitalized is somewhere around 400 or 500. The number of cases are well over 1,000 for Travis County.
Okay. And then the next question is, when will testing be available through Baylor Scott White?
Testing is available at Baylor Scott White in our emergency rooms for patients that are ill and meet the appropriate criteria, as well as for selected outpatients at our Round Rock 425 clinic location now, and have been. We were among the first locations to offer drive-through testing for patients who are appropriate, meeting the appropriate criteria at initially our North Burnett location and then at other locations. But now we've centralized that as a part of a community-wide effort, including the other hospitals in our area, as well as the Lake Travis Public Health Authority, to have it widely spread throughout the community. But again, testing is largely limited to patients who are symptomatic, and I'll explain why, and often patients who meet our appropriate criteria, which most patients who don't have symptoms or don't have clear-cut symptoms of this don't meet. And the reason for that is limited testing capacity for the tests that we do at Baylor Scott White, which turn around within a day or so. Some testing facilities, including Quest, are offering tests, but those may be 5 to 7 days in delay and perhaps longer. I know that there are public reports of people who had tests a few weeks ago, but still haven't heard the results.
Okay,
Other questions, Stanley, or I can go on?
There's one more. It says, after learning of the spread of the virus to big cats at the Bronx Zoo, can we spread the virus to our cats at home?
We believe that cats, including the big cats in the zoos, are a potential risk. I'm not a veterinarian. I'm not in a position to tell you how sick your cats might be from this. What little I've known from understanding that was spread to the large cats, you might sit there and say, how did the cats get that? You might question, where is the social distancing there? But we believe that was spread from an asymptomatic handler of the tigers in the zoo. And so that, in that case, was, again, an asymptomatic transfer from a human back to a cat. I can't tell you about cat to human transfer, but that I'm sure someone will be looking into. And I believe the reports are that cats have a relatively mild cold-like illness, but I can't tell you any more about cats. Let me go on and talk a little about testing, since that was brought up. Testing is currently done in one way and will hopefully be done in multiple ways soon. The most common is preliminary chain reaction, which is a fancy way of saying I take a swab from deep inside your nasopharynx, which isn't fun, but is quick and easy. That's what they're doing at those drive-by testing locations or in our emergency rooms when it's appropriate. And that testing then is done in a lab, and within a relatively short period of time, a day or so, it gives us an answer. More rapid testing is on its way. We are hoping to have testing soon that will tell us within 15 minutes, like it does for a strep test or certain types of other tests, if the presence of a virus is there. Now, we believe that if someone has symptoms and the virus present, that equals disease. And that's kind of how we're operating. But we have to realize that before you have symptoms, you may not have enough virus in your nasopharynx to detect. And that's part of the reason why we're not right now routinely testing asymptomatic individuals, because we fear that we might have too many false tests. In that case, the test most likely would be falsely negative. Patients might go on 2 or 3 days later to have positive results and positive symptoms. And we don't want to mislead people. Additionally, they were hoping to have immunologic testing before too long, where they would take blood out of your arm and be able to test for the presence of immunity, either early immunity, we call that IgG, or later immunity, we call that IgM, that would tell us whether you have been not only exposed, but whether you are now immune to the disease. Now that will be very valuable in helping people decide who can go back to work, because if you're immune, you will probably be in a position to not fear the disease, although we don't know right now, obviously it's too soon, how long immunity from those who have had the illness will last. But we're hoping that it might be long-lived. But that's part of the research puzzle that's going on right now. Additionally, you have to think about how useful this information is. I'm going to contrast it with influenza testing. I'll do influenza testing early in the season, in November, maybe early December, to try to get an assessment when someone comes in and has some symptoms that look like influenza, but I'm not sure, or perhaps later in the season. April is a good time to test and say, is that really influenza? Because it's kind of late in the season. But during the height of the season, most professional organizations do not recommend influenza testing. And for the simple reason is if you have influenza symptoms, cough, high fever, runny nose, you probably have influenza because it's an epidemic at that time of year. And it's best in that case, because of what we know about influenza, for you to be treated with medications that can stop influenza, or at least limit its symptoms and limit its transmissibility to others. And those medicines don't work for COVID though. And so in that time period, for those patients, we may not test influenza patients, even though we know they have it. COVID will be something similar. I suspect that we'll be testing a lot of people now where we're trying to get a better answer. But before too long, we probably won't test patients who have classic symptoms and meet other types of medical criteria, because we will know that they have COVID. And we will probably rely on better testing down the road. Right now, of the people who are getting it, most of the time, those are people that are being hospitalized to tell us what to anticipate as best we can. And a lot of times it's healthcare workers so that they could be returned to work at the front line. And in some cases, first responders, so that if a paramedic is exposed, that person can be sequestered for a period of time, tested, and hopefully returned to work without an undue 14-day period of quarantine. That's a lot of the people that are being tested, and I know Baylor Scott White is partnering with many local first responder organizations to be their primary testing location to help us keep as many healthcare workers, but first responders on the front lines where they're at. We're hoping that it'll be more broadly available soon, but I can't tell you when. Does that answer the questions about testing, Natalie, you think?
We do have another question. It's about immunity. It says, is there, and it kind of follows that same vein, is there an immunity among those who have recovered?
We are presumptively assuming that people who have been infected and recovered to be immune. We don't know how long that immunity will last, because as an example, when you get a cold virus, it doesn't mean that you won't get a cold virus down the road, in part because there are multiple viruses. We believe with COVID that there will be unique immunity and it will probably be somewhat long lasting, but I think people are reluctant to say that. We know that with vaccines, different vaccines have different degrees of persistence of immunity. That's why in some cases we get boosters for our tetanus shots after every 5 years if we have a dirty wound, and 10 years if we haven't. Or why we're making an effort in older patients who have exposures to grandkids to specifically make sure they get the pertussis vaccine because we don't want older people who are potential reservoirs of pertussis to spread it to children. So there are obviously things that we don't know, but right now we believe that if you've had COVID, that you're safe, at least for months, probably for years, and we'll be learning more as we go along from that. Does that answer that? Go ahead.
There's another question in that same question. Are studies being started to test for natural immunity among people who haven't gotten sick?
Yes, and I want you to think that there's belief that there is no natural immunity from COVID-19. It's not like our bodies have ever seen this virus before. Whereas, as an example, for in other influenza viruses, many people, ever since the initial H1N1 outbreak in the Spanish flu of 1918, most people have some degree of immunity to H1N1 influenza. But we don't believe that people have native immunity. Now, that being said, we know that the current seropositive rate in those populations that have been tested in the United States is 0.5%. If you look at Wuhan, China, and this is information from the University of California, San Francisco's internal medicine grand rounds last week, the current seroprevalence of immunity in Wuhan, China is 2% of the population are proven to be immune. Now, there's a lot of information and data that will come down the road, and so these are very preliminary data. But that would still mean that in Wuhan, China, 98% of people are not immune, and that other public health measures will continue to need to be used to help protect people until we're about 70, 60, 70%, at which point herd immunity reduces the likelihood of transmissibility of the disease, so that even if someone was to develop it, they're not likely to transmit it to anybody around them because other people around them already have immunity. That's kind of a little background about that. Other questions, Cindy or Natalie?
No, I think you're good to go on.
Okay, so then the next question is what can doctors do if you have COVID-19? We see a lot of questions. We've done e-visits on our website, and we encourage patients who feel that they have significant symptoms to do e-visit this afternoon who has that question of whether they have COVID-19. I've interacted with patients who have pretty confidently felt that they've had COVID-19, and I would agree with them that they have probably COVID-19 even without testing because of their symptom pattern and how they are recovered over time. But what doctors can do are somewhat limited, and this is a very humbling experience for most physicians. We're used to giving penicillin since the World War II for strep throat and cure these diseases. We do not have medications that, to our knowledge, cure this disease. We do have some early evidence that some medications might help mitigate it by reducing how fast the virus can attack people. And we know that we have methods to help care for people who are sick, whether it's symptomatic care for their cough, trying to exclude other possible illnesses, be it influenza, strep, other forms of pneumonia, which are still going on. We're just coming to somewhat of an end of the major oak pollen season. A lot of people could tell me that, no, I don't think this is COVID. I think this is my oak virus or my oak allergy. I've had this every year, or they know. And we often take that information from patients with great concern. But for a lot of people, it may result in them using oxygen and staying at home, isolated from others, so that they can't spread the disease. Our plan in our household is if I came down sick, is that I would be in a bedroom by myself and a bathroom by myself, and I would not come out until I was well. And they would check on me with video visits, just like we would check on you, and hopefully keep track of where you're at. And obviously, we will be using home health providers to help us with that. Obviously, in rare cases, we believe that maybe more than 10%, depending upon the age and other illness, may require hospitalization. And of that group, some, hopefully few, will need life support beyond oxygen to keep their oxygen levels up and keep their organs working and monitoring tests. And some of them will need life support, which we mean are ventilators. Ventilators are mechanical devices that essentially breathe for you and can provide pressurized oxygen at higher levels than what we have in the normal atmosphere to help your lungs who are diseased still get enough oxygen for your brain and your kidneys and the rest of your body so that you can fight this illness off. If you look at the published research, most patients have been on ventilators for a week or two. And again, part of that is that it takes about 8 or 9 days for your body to develop initial immunity. We often see patients and patients where they may have complications and try to monitor and care for them. And then obviously people need time to have their lungs heal so that they can breathe again on their own and then go home, often needing further time to recover and gain their strength. Obviously, in some cases with their regular medicines being adjusted or nutritional support being provided, with home nurses being involved, with even home physical and occupational therapy to recover from the weakness that comes from this, just like any other very serious illness that can occur. We believe that most patients will probably be through this illness in a little over a week if they have a mild case, hence the 14 days that most people are thought to stay at home if there's a question about serious contact. But we know that some people will take longer to recover just because they may feel very weak from this. And again, we talked a little bit earlier about the immunity. Right now, we presume that once you've been treated, that you're not going to get sick again. I don't think that that means that people should go out and cavalierly do risky things, but that may mean that certain healthcare workers, as we saw with the Ebola crisis in 2014, if they were recovered from Ebola, they were in better situation to not need protective equipment or as much protective equipment as those who had had no exposure to it at all. So that gives you a little bit about treatment. One of the things I want to underscore is that there's very little that we can do in the office that we can't do on video or telephone to help address this with patients that I've met for the first time in that venue or who we know well. So I don't want to discourage anyone from seeking out and getting attention. In fact, I want to encourage you to seek out and get attention. We'll talk about that more later, but specifically to realize that, you know, I'm not going to call in a Z-Pak for you or put you on hydroxychloroquine based on the evidence that exists right now. There are studies going on. In fact, my brother-in-law is in charge of the Institutional Review Board for a major healthcare provider up north, and a lot of that research is being done, and I suspect we will have preliminary information back very soon as to how valuable those are. And there's a lot of other tests that are being done either on a compassionate use basis with permission from the FDA from many different kind of drugs, but we don't have evidence to point to that says, aha, here's the magic bullet yet. That will come. Other questions about initial treatment and triage to hospital level of care?
Yes, we do have another question. The question is, why are we not using closed hotels to quarantine with medical supervision patients with low levels of COVID-19?
That has happened in other parts of the world. That has not happened here yet. The public health officials have that power to do that if they so choose. They have not yet. I suspect that that will be kind of part of what comes next, and we'll get to that in a minute. But I want to talk a little bit about first, is there other questions, Cindy, before I go on? Or
No.
I want to talk a little bit about what we can all do to help reduce this illness. And many of us are already doing it because we're sitting here on our computers or on our phones talking, as opposed to being at the library where we were going to be in a larger group. So we're already doing something now. And we've already, for the most part, been in our homes now for how many weeks? You know, or those that like me are coming to the office. I'm sitting in my little office, which is where I'm at right now, talking to people on the phone or seeing them on video chat and helping deal with their medical problems. And we're doing our best, even within our clinic, to wear our masks. Where's my mask? I got it right here. All right, this is my doctor mask that I wear when I'm here in the office or when I'm out. I've got my mask that, since we leave our masks here, because of the shortage of personal protective equipment, I have my mask that I wear when we're out walking or in public where we might come in contact with people. Although I think people are doing a very good job of trying to stay apart, that 6 feet, even walking on sidewalks. People go onto the street, stay apart, and that is very important. We also want people to stay safe by not isolating themselves if they're sick without people knowing about it. Just because we're, quote, socially distancing ourselves, I want people to think of that as physical distancing themselves. This is an important time to make sure that you have contacts in your family or with the healthcare center who can keep track of you if you're needing help. The idea of that 6 feet and 10 minutes was the concept of close contact. We talked a little bit about that earlier, but there are other very simple things that we can do. We know that besides wearing your mask when you're out, you go to the store, you wear your mask. You go to the gas station, you wear your mask. You might go to the post office if you have a postal box and get your mail. But outside of those contacts where you're wearing a mask to protect others from anything you might have, and to a limited degree to protect yourself from them. Now this mask, which I'm very proud to tell you is made by my son, has a filter in it. But many cloth masks that you can make at home can also provide benefits as well. And for the most part, the other issue is to wash your hands, okay? Wash your hands 30 seconds. That's, happy birthday twice, or the ABCs twice, with soap and water under warm water, all right? Scrubbing all the different surfaces of your fingers, or using, when necessary, hand sanitizer, all right? Yes, I know I have one of the few bottles of hand sanitizer in our clinic right here as a prop to show you. That little drop, all right, can make a big difference on your hands if you're not in a situation where you can immediately use and wash your hands. Let's say you're out at a store if you have to be there, or you're touching things that have been delivered to your house and you're not sure where that might have been. That type of protection can mean a lot. And if you wash your hands and you use even a mask, even if you're using your mask, just to keep your hands away from your face, okay? And I know that everybody who's watching this, who knows me, knows that I tend to have my hands in my mouth. If you just use your mask to keep your hands so that you're not getting them in your eyes and you're not getting them in your mouth, that too will help protect you, particularly when you're out. Because that tendency is to touch something and then put something in your mouth or in your eyes or your nose, is how we believe this disease is transmitted. And that is very simple hygiene. And hygiene is a very important part of public health. We talked a little bit about masks. I don't want people to think that they're bulletproof, but I do think that the recommendation currently to wear masks will last for a long time. And so I think that people should prepare themselves and have them. They obviously, if they're simple homemade masks, can be laundered and kept clean. Obviously, the part that we're worried about is typically the outside of the mask where you might have breathed something in or where it might have come in contact with something in the air. If you're sick, it's the inside of the mask, and you might want to keep your hands away from them. Just like when I'm touching these masks, I touch the cords. I don't touch the rest of the mask. And if I was a good soldier, I'd be wearing my mask now, but most of you would have a harder time hearing me because I mumble too much. The other things that I think that are important is that people need to keep moving. Just because we're in physical distance doesn't mean that we necessarily shouldn't get up and move around. This talk has gone on for about 40 minutes, and we should all be getting up and moving around because we now are beginning to see patients who have social distance who are developing diseases like blood clots from sitting too much. And those patients are at risk. And we also know that there's an important part of exercise to keep us well so that we are not unfit if we deal with this virus. And even if it's every 30 minutes, you get up, you walk over, you look outside, or you walk to your door and open the door and get relief from the nature deficit that many of us have, or you turn off the news, which is often, what's the right word? Probably not good for your health. To quote John Prine, maybe we need to blow up our TVs because some of the information that we're getting is probably not terribly helpful to our peace of mind. And then also do other things, get our minds engaged with reading or in talking to people on the phone and communicating or in praying and interacting with our neighbors by that type of contact so that we can help make sure they're safe. Maybe they can go to the store and get what you need and so they can save you a trip, or you can, if you're out, save them a trip, and then so doing reduce the risk to everyone. Does that give you a little background of what we can do? Does everybody have any questions specifically about what you can do and what you can do within your family, within your household to help stay safe? Let's answer questions about that if there are any.
I have a question about the homemade masks being made for medical personnel. Do you feel like they really can be used by medical personnel, or is it kind of pointless?
I'll give you an example. If we're short on personal protective equipment and I'm in a hospital where I have to do an aerosolizing procedure, the highest risk procedure that we have to do is when we're dealing with someone who is going to cough on us, who is going to breathe and put out stuff from their respiratory system on me. I can wear my N95 mask that goes around my face and nose, right? And we're very appreciative of people who have donated masks to our community and to our hospital, all right? But if I wear that 95 mask in my organization, I can wear my cloth mask from home over it. That tells you how valuable that type of thing can be, even in the highest risk circumstances. But I do believe cloth masks help us prevent us from spreading it to other people before we might come down with symptoms, and hence we don't even know. And I do believe that there is some evidence that they do reduce us breathing it in a little bit. Now, I'm not saying it's as good as an N95 mask, which is not recommended for public use, or even a surgical mask, because right now these surgical masks are in short supply. And they need to be reserved for first line responders and medical personnel. Because we don't want to be in a position where, you know, we're homesick and can't take care of you, can't draw your labs, can't do your x-rays, can't get you to places you need to be within the hospital, or get the food you need or your room's cleaned, because we're sick and out. And we know of healthcare organizations that have had anywhere between 5 and 20% of their frontline staff become ill with this disease, some who have died. And so we're trying to make sure that we're there for you. Other questions, Cindy or Natalie?
Yes. Is fever always a symptom?
Fever is thought to be one of the primary symptoms. I believe it occurs in, we now think is 80% of cases, but there are cases without or with limited fever. In a circumstance that I was aware of, one person had very little fever. His wife came down with the illness 3 days later, just like you would predict, and she had high fever. In that case, neither one were tested because they did not meet the more stringent criteria for testing. They were fortunately ill and sick for a time, isolated themselves, and then recovered. But another person in their household never had any symptoms at all. I do not believe that person did not have the disease. I believe they probably were asymptomatic. As we know that 20% of the people who tested positive on that one cruise ship that was ultimately quarantined in Japan, 20% of those patients had no symptoms, and yet were at a risk for spreading the disease. Now, we do know that people who are sicker spread more disease than those who don't. But right now we have to believe that in some ways, almost everybody is at risk for spreading the disease. Other questions about how we can take care of this?
Yes. So one of the questions is, should we clean our mailboxes, groceries, etc., when we bring them into the house?
I meant to do more research on this, but I think the simple answer is that it is not wrong to use either soap and water or a disinfectant wipe on anything that you come in contact with. And that would include things that you might put in your refrigerator or your freezer before you do it, or in your cupboard. I don't think it's unwise to do that. I don't think we have perfect data on how likely that is to spread disease, but it's, in this case, or at least until we have better information, a wise practice.
We're going to ask people now. People have been writing questions in the chat, and that's worked out great. Now what we'd like to do is ask people to raise their hand if they'd like to ask a question. And Natalie's going to unmute you if she can see that you have raised your hand. And the way that you would raise your hand, Natalie, do you want to describe how to, I think you just, yeah, hey. The other is maybe you could do a reaction. If you go down to the bottom of your screen, you could do a reaction. And one of the reactions is, well, there's a clap. I guess you could use a clap to raise your hand. I just clapped so you can see that. Here's another question while we wait to see if we have anybody raise their hand. If all members of a household have the disease, do they need to stay in separate quarters?
You know, the question, the answer in part is where are they at in the transmission process? That is a good question. And I would think that then in that case, we need to probably make sure that we have sequestered ourselves as a family until after that last person would have been conceivably exposed and symptomatic for that 14-day period of time. But no, once you're in amongst people who are positive, like the comment earlier about do we sequester people in right now the hotels that are empty? No, they would not necessarily worry about transmitting the disease from one to another.
Okay. Natalie, do you have any questions from people who are raising their hands?
I saw one hand up.
I think it was mine, maybe.
Betty's hand. Betty, talk to us.
That's the only one so far.
Hey,
Yes,
Betty.
Unmute Betty.
Betty.
There you go, Betty.
Okay, I have stayed very isolated since this began, but I'm wondering about having workers, like cleaning people in my house. I have not allowed anybody in my house. I live alone, and I've been very careful wearing my hazmat suit to the grocery store and stuff like that. But so that would be my question. Is there any way I can have? I had one air conditioning guy in here, and I mean, I just threw him out.
You know, I think it depends on the risk and the benefit. If your air conditioning goes out and it's 100 degrees, then I think it's reasonable to take precautions and make sure that your environment is. If you're an elderly person who needs physical therapy, I think all the home care workers that I know of are being very careful and trying to reduce any possibility that they're spreading it. My staff checked my temperature when I walked in the door today. We do that on everybody. And obviously any healthcare worker who is ill at all is being requested to stay home until we can clarify what their symptoms are, or in rare cases specifically test them. But if you say, I have workers come in, do I need them? Maybe not right now. Maybe not right now. But I don't want to discourage people from getting appropriate home nursing, home physical therapy, home occupational therapy, if that's going to make a difference in them recovering from an illness or in staying well from an injury or stroke or something like that. Did I answer your question, Betty?
Yes, thank you. I'll keep cleaning the house myself.
We do have another person who's raised their hand, so I'm going to unmute him.
Okay, great.
This is Jim.
Unmute Jim. There you go.
Hi. Why are type 2 diabetics whose diabetes is well controlled at greater risk for this disease than the general population? Thank you.
The basic understanding of diabetes is that that high levels of sugar, even in patients who are well-controlled diabetics, can affect your immunity. Hence the reason why we pay attention to what your feet are looking like and looking for skin infections. Why we are perhaps a little more ready to treat you for a respiratory infection with an antibiotic when we're not even 100% sure it might be a bacterial one, is because we believe that high sugars, even within the well-controlled diabetes range, can make a difference in your immunity. Obviously, there's information that even came out this morning that basically said that heart patients, even those with hypertension, are at greater risk. And you might say, well, hypertension? That affects many of us, including me. And you sit there and go, well, how could that? We don't know, but we do know that there's enough risk, enough of those patients who are showing up ill in the ICU that we need to pay attention to that group of people. And we have some of our own healthcare workers who are working from home because they meet those criteria for having serious risks. Did that answer your question, Jim? All right.
Yes, it did. Thank you.
I'm going to try to give you also a little background on public health because I want to get to the point of how does this change and how do we go from where we're at now to essentially the future? Because it's obviously become clear that in some ways we can't essentially assume that we're going to be doing this forever. Not only is it not possible that our economy could work like this, but yes, people's air conditioners will break and they'll need help and that will go on. So a little bit about public health. Epidemics have been around for humankind as long as humankind has existed. And the first word is always to flee epidemics. And I mean that with the pun intended. And that the first major epidemic we have a lot of historical information on is the Black Death of the 1340s, the bubonic plague, which rarely occurs in humans now, spread by a bacterium through a flea carried on rats, on ships. And the idea, for a historical note, of the word quarantine meant 40 days. And they picked 40 days probably out of the Bible. And the idea was that if you were bringing cargo to Venice, you had to stay out of the harbor at an island with a plague flag, the way they are yellow, up for that period of time until everybody knew that you had been either sick, died, or you were okay to come ashore as a means of trying to reduce disease. And these were public health measures before we even knew what public health was to try to reduce disease. Now, obviously, there have been plagues of bubonic plague across the world for years. And in fact, Isaac Newton discovered calculus and gravity during a lockdown for the bubonic plague where he lived in Cambridge and Oxford. Shakespeare wrote Macbeth and King Lear while on a plague lockdown in London. So we can get a lot done during shutdowns. It doesn't mean that we can be unproductive, but there are other more recent ones. Cholera, which is an evil waterborne disease, can kill you within a day as a diarrheal illness. Had public health solve the problem when, we looked it up today, 1854, Dr. John Snow in London had mapped the deaths in a part of London that had affected a given hospital and looked at where they lived, and they were all clustered around a well. And so does anybody know what he did? He took the pump handle off the well, and in so doing, stopped the outbreak of cholera in London. But more recent issues that have come up was that Dr. Walter Reed discovered that mosquitoes transmitted yellow fever, and that affected our efforts to build the Panama Canal and many soldiers that were ill in the Spanish-American War. And he drained the swamps and reduced mosquito exposure, which also then reduced malaria and other illnesses. And we know even in our location, the Bat Bridge on Congress Avenue in Austin was in part a public health measure to encourage bats to live there, to reduce the mosquito population there. And there are other examples in San Antonio of that same type of issue. More specific to the COVID virus, we have something to learn from the H1N1 influenza of 1918 that killed, we believe, 50 million people worldwide, and more than 500, I believe the number is 675,000 Americans in 1918, where there were very little mitigation efforts in some communities, specifically in Philadelphia. Near the end of World War I, they held Liberty Bond rallies in Philadelphia and did no social limiting. And they had a very high death rate in Philadelphia in comparison with St. Louis, another community, who then did do significant social distancing and had a much lower death rate and much lower deaths overall. Even though obviously the disease continued to spread, it wasn't a way of eradicating or curing the disease. More in my lifetime, I remember and at one time actually practiced seeing patients in what had been the TB sanatorium in our community in Wisconsin. And we took patients who had tuberculosis, who some escaped to places like Glenwood Springs. I remember Doc Holliday going up there to try to get away from the pestilence, realizing only later that high altitude and low oxygen made a difference in the growth rate of tuberculosis. That's why it worked, and that's why Thomas Mann wrote The Magic Mountain. But the point is that type of sequestering made some difference, but TB sanatorium was designed for patients who were ill before we had effective treatments. And we didn't have effective treatments until the 1950s with spectinomycin. But again, in my lifetime, smallpox was eradicated in 1980, and that was done by more shoe detective work, where you'd find a case, you would vaccinate everybody around them, and you would try to limit the spread of the disease. Ebola, a very similar thing. In my brother's history, I remember him telling me about the swimming pools being closed in the 50s when he was a young man because of the problems of polio, until the Salk vaccine came out and later the Sabin oral vaccine came out. We're all hoping for that type of thing. But right now, that gives you a little bit of background on public health. It is important for us to realize that public health powers are overwhelming, all right? And we might not like what the government can do, but when it involves public health issues, they have powers to do almost anything, all right? If I'm in a situation where a public health officer says I have to be quarantined in my house and I leave my house, they can arrest me and they can keep me wherever they want, and as long as that's public health emergency exists. And I don't have much to say about it. All right, so I wanted to speak a little bit about how will this particular era that we're in will end or change. I suppose I don't want to really say end because I'm not sure that's the right word for it. And I got a little handout that I want to talk about. Where did I put it? Here it is. All right, and this is, again, the best epidemiologists telling us what they think is going to occur and how are we going to be able to open up our economy, become more active in our community, be safe when people come into our houses to help us with various different things, and go about. And that's changing. This is an unclear science, so I don't want you to think that I have all the answers. And this is actually from that same internal medicine ground rounds last Thursday at the University of California, San Francisco. And their lead epidemiologist, young man, or not young, Dr. Rutherford specifically said that we will have to look at when the transmission rate is low. Now, right now, the transmission rate is not low, but there are low numbers of new cases. We're beginning to see that go down in communities, that there are low numbers of new hospitalizations. We're beginning to see that crest in communities like New York, where right now there are more discharges than there are admissions, and more people going off ventilators than going on ventilators, even though based on the history of when they were exposed and when they're sick, They're still very, very, very busy. I like to think of them as whelmed, but not overwhelmed yet. And we're well prepared here in our community and throughout Texas for that. We are not predicted to be at peak illness until later this month or maybe early in May. That obviously changes with the models, which obviously are inexact, but that we should be well below the maximum capacities of our hospitals and intensive care units and ventilator capacity. We also have to assume that we will be working in an environment where the seropositive, the number of people who have been immune, are low, and that we will have to then track down through aggressive testing anyone who is sick or potentially could be sick, and at that point try to sequester them, just like we sequestered patients with smallpox in parts of India when it was eradicated in 1980. And that we must be able to track people who are sick and keep track of them. We know that many of the major technology companies are working on ways to do that right now. And yes, that does involve significant privacy issues. But if it allows our economy to operate and for people to go to stores with less fear, wearing their masks, that'll be important. Obviously, we have to have adequate hospital and ICU capacity. I think we're blessed in our region to be well prepared for that. And I've been part of some of the surge planning and surge discussions, so I'm reasonably well informed as a frontline provider and as someone who's volunteered to help if that's needed in the hospital. And that we need to continue to have probably some restriction on mass gatherings. I probably, from my own point of view, would not anticipate many mass gatherings happening in the next few months. That would include sporting events. My son's high school graduation might not occur in the format that we would normally think it will occur in. And that from this community and for my patients, specifically, many older people will need to shelter in place for an indefinite period of time, in part because we won't know until we have vaccines who we might come in contact with that could spread the disease to us. And that's where we have to work together as a team, neighbors helping neighbors, families helping family members, to try to reduce the spread to vulnerable populations until we have a vaccine. And that means that we have to explore what options will work for schools, wearing our masks when we're outdoors, and for those who are able and at low risk to return to work, maybe staggering their work shifts so that they're not clustered in the same way. Or that may apply in schools where there will be less clustering in schools and a little bit more distance to help them. That's what it'll probably take for us to get through this and know what the next few months are like. But that, of course, is very preliminary information and it may change relatively soon. Any questions about what the future might look like and how we'll get there?
I've asked this question before. My mother lives with us and she's 82. What do you suggest when you have somebody who's older and has some of those issues, health issues, for us? I know we need to keep her safe. What are the steps that you can do to keep your family members safe?
It gets troublesome when many family members have had, as an example, the benefit of their grandchildren have been sequestered from school. They've been kept apart. And so, they've obviously, if they had contact, spent a little bit of time apart, but now they've been together because everybody's been out of school and everybody's been working from home if they can, or staying at home if they can. And now we might see people trickling back out into work or to school or into other activities. And that's troublesome. I think probably higher risk people will have to stay more sequestered and be more protective from people who are going out and about. Because again, I could go out to the HEB. I could get gas. People talk about, the gas pumps being the filthiest thing out there. I don't know if I've ever wiped off a gas pump in my entire life. But the point is we might do some of those things because when I come home or come from here, I might even unwittingly be in a position where I might be spreading illness to others. And so there's still a lot of uncertainty about in mixed families, mixed generational families, or in families that have gotten used to interacting with their grandchildren. If their grandchildren go back to school in September and there's still no vaccine, it may be a point, particularly if they're at high risk or immunosuppressed, that they may need to stay away from small children. Many small children won't have much in the way of symptoms. And even though they can, they may not know that they are ill. And hugging grandma and grandpa might be a bad idea at that time. We hopefully know more over the next few months to answer that question.
We do have another question. Can you please explain how a video visit works with the doctor and if I can get my routine checkup and medications this way?
That's a perfect question for what I wanted to talk about next, which is we are here to help you, all right? We are fully staffed. Patients, we have obviously staff here in the clinic where I'm at now, but even at other days in the week where I may be practicing from home in my home office, we are here to see you in person like I am right now, or on the telephone for patients who are more technologically challenged. And we have multiple different platforms to do that. We have our Baylor Scott White Health app, the little app where you can find out, make an appointment. You can log into your appointment. You can see the physician or other provider who is speaking to you. And obviously in that case, we can do your Medicare wellness visit. We can refill your meds. We can talk about how you're doing. And I wanted to go over a little bit of how to be prepared for those visits so we can get the most out of those visits. We can make sure that if another problem comes up, answer your questions about, is this COVID? Is this something else? What should I do? I don't want to run to the hospital or run elsewhere to get answers when we can give you those answers in real time every day. I also want you to realize that virtual appointments, I think, are good. I mean, I'm going to tell you a story from when I was training. My lead physician, my chairman, is a guy named Milt Homolsky, a leading scientist from Boston who had run our hospital for a long time. And he taught me something that I've tried to do all these years, which is that if I don't know what's wrong with you, when I've asked questions and tried to get a little bit of history about what's going on and when it started, if I don't really have a good idea, I better sit back down and ask you more questions, because I'm not going to find out a whole lot on a physical exam or on lab work that I don't have a good suspicion of to begin with. Doesn't mean it never happens, but it doesn't happen that much. And we have the capability, if needed, to see people outside who are ill where we need to make a terribly difficult triage decision, and have. But for the most part, we can manage 90+% of what we need to do virtually, like we are right now in this type of conference setting. Now, we're not using Zoom at the clinic because of security issues for patient care, but we are using FaceTime. We're using a technique called DoxyMe, where you might get a text with a link and you go right there and I'm right there listening to you. Or obviously what we prefer for our ability to integrate it with our electronic medical record for your comprehensive care is our My Baylor Scott White Health app. We obviously have the capability still within the clinic to do labs, x-rays, EKGs. We're still doing well child checks for children who need vaccines. We don't want anyone's care to be dropped, particularly at this time when they're at home and maybe fearful of coming out, which I don't blame them for. Obviously, we're here to help guide people who might need a decision to go to the hospital and when they might need to go to the hospital, or if they're coming out of the ER, they may need continuing care, or out of the hospital, they may need continued care. And we want you to know that we can do that, and just like we do any other day. And in fact, if anything, believe it or not, we're more on time than we used to be because we're more attentive to that. So that's a good thing. And we are your local primary care connection. So is there any question about how you can get help and what we can do to make your visits valuable?
Is there technology that you should set up beforehand, or when you make the appointment, is it enough? So should I set up for a potential urgent need now, or I guess that's my question.
You know, I have seen virtually and talked to virtually many patients who are new in our community who do not have primary care, and who have dawned on them that this is a really good time to have a primary care person they can trust, that they can talk to, who knows a little bit about them and how they function, what their day-to-day life is like, how they manage symptoms before they get ill. Mm-hmm. When they do get ill, they have someone who knows a little bit about them and that can work with them, that they trust, that can help them navigate the healthcare system. And I think that's terribly important. So if people don't have local providers, I encourage them to have providers. Virtually all providers right now are providing these kind of virtual visits. And we started very early. And I've done virtual visits now for the last year and a half for patients. Some of them are in Wisconsin, where I came from. But even for people here who are new, who have never met me. I did one last Friday afternoon on a fellow from a community 30 minutes away who said, you know, I'd like to talk to you, and established. And he said, Norm, I'm used to, meeting doctors, but I think that we were able to communicate and come to an agreement to his satisfaction over what his concerns were. And I believe we can do that for each and every one of you as well. There are going to be times when we have to make a hospital decision, or when we're managing an emergency room follow-up where someone's been sent home. We're committing to make that possible. And also where, we can help guide people as we're able to do more elective procedures to try to get those procedures done efficiently. We don't want people whose procedure might be put off for a month to be put off for 6 months. That might not be possible for people, and we need to help you navigate that. My little soapbox to stand on is that primary care is one of the few things in current research that lowers healthcare costs. In a study done in Rhode Island, where I was trained, they made a point of increasing primary care expenditures from 7% of all healthcare expenditures, a very small amount, to 14%. And they saw that overall healthcare costs went down. That's one of the very few studies that have actually shown healthcare costs going down. And obviously, if you look at some of the research out of the Journal of the American Medical Association, adding primary care into your world, into your community, increases everybody's life expectancy by about 2 months. And we obviously can help, not perfect, none of us are perfect, that's why they call it practicing medicine, to avoid complications, whether it's polypharmacy in older people who are getting medicines from many different doctors and no one's really being holistic and putting it all together. And also trying to make trade-offs about, I got this medicine from this doctor, but it seems to conflict with that or causes this side effect. How do I decide what's important and what's not? We're not here to overrule the specialist, but we're here to help people make reasoned decisions about what will work for them. That's a little bit of my soapbox about primary care and why I've been a dedicated primary care provider in internal medicine for my entire career. Other questions right now?
Yes. Is it safe to get lab work for an upcoming doctor appointment? I'm a high-risk type 2 diabetic.
Yes. And in fact, what we don't want to have happen is that your underlying illness, your diabetes, your hypertension, your heart disease, get out of control because of lack of appropriate lab or follow-up. And when you are interacting with the doctor, it may be appropriate that you have your blood sugar records with you, just as you would when you come into the office, or your meter if it has memory on it, or your blood pressure readings if you're able to check it at home. Again, having your list of questions, what medications might need to be refilled, can, as in any visit, make your visit more productive and more helpful so that you come away with all the answers that you want and that you feel that you are prepared for whatever might come your way.
So when you go in for that lab visit, should you wear gloves and a mask? And obviously somebody's going to touch you, and should they have gloves on? And what should you look for in that case?
Okay, before you enter most medical facilities right now, you will be stopped at the door and you will be asked about 12 questions. They include fever, sickness, a whole list of symptoms. And that list is changing as the public health officials ask us to change it to be carefully identifying. If you do not have any of those questions, you come into the clinic and get your lab or your x-ray or whatever. If you are symptomatic, you're sick, you meet those questions, you will be given a mask. And at that point in time, depending upon what you're there for, you'll be escorted to the lab to get your lab work done, or escorted to x-ray to get your x-rays. And it may be not through our waiting room. It may be through another door to the clinic here or other clinics, so that you are not in the waiting room where you potentially are being exposed to others or exposing them to you, if that's the case. And that's the routine in all healthcare. If you go to the hospital right now, you have to go through the hospital's ER entrance where you will be asked those questions and your temperature will be taken. And that's how we help protect one another from this spread. I can't tell you that wearing gloves will make a difference. I do think washing your hands and using hand sanitizer. We've already talked about the importance of, if you're out and about, wearing your mask. And I certainly think that that's a good idea, to wear your mask when you're out and about, coming to the clinic or doing anything. And that'll be true for months, if not longer. Does that answer the question, you think, Cindy?
That answers that question. Natalie, do you have anybody else who's raised a hand? No. So one thing I'd like to, for everybody who is on this call, is for you to go to ltseniorservices.org. We have a tab there with COVID list of help for you. So it's anywhere from using the HEB Favor app for seniors to places that you can go to for additional help that you might need. So we have a tab there with information. If you as a community member have something that you want to add to help LT Senior Services, please let us know. We don't have everybody's email address. We see a lot of people that we don't know from before. I'm sure it's from Dr. Murdy's practice. We welcome all of you. If you'd like to come to next seminars, you can sign up for our email distribution list. We have a seminar each Monday. Next Monday, we're also going to be talking about COVID. The next Monday, we're going to be talking about scams. There's a whole bunch of scams going on right now Of course, situations like this bring out bad people. One of the things we want to communicate first is that nobody's going to call you and ask for information in regards to your potential check that you're going to be getting from the government. Don't answer any questions. Don't give driver's license, anything like that. That is a scam right now going on. The government is not going to call you. But this person was already going to be talking about scams, and now we just have a whole bunch of COVID, unfortunately, related items. Natalie, can you think of anything else that we might want to share? Oh, somebody's asking, how do we get access to this recorded session? We'll have a link on our Facebook page and on our website. It will lead to a YouTube page. We're going to be posting this to YouTube. It's going to be a private page, and so you're going to have to register. So we'll send you a link, and then when you go to the link, and it's not going to be set up for a while, we're still figuring out technology. So give us a couple days, but there'll be a link on the Facebook page, LT Senior Services. It'll lead you to YouTube, and you'll register. We want anybody to be registered before they can see our videos, and the video will be posted there.
And I'm also going to put my email in the chat. And if you have any questions or need help accessing any resources, you can always contact me via email. So I'm going to put that in the chat right now.
Excellent. Any other questions for Dr. Murdy? If not, we're going to sign off. I'm looking in the chat. Oh, we have another question. Oh, that's from Natalie.
I'd like to point out one thing, Cindy. This is a very serious illness, but there is a lot of hope. First of all, the people that are represented on this chat have been through many other serious issues, whether it's World War II, the Cold War, the Korean War, the Vietnam War, or other types of things that had serious health implications. And I don't think that we should realize that this is drastically different than other types of things that we have faced. We do need to work together, and we need to realize that through this process of washing our hands, wearing a mask, being careful, and being aware of how to use it and to use our medical system wisely, we all become healers. We all become part of the solution, and that will help get us through this to the point where we are able to put this in the rearview mirror and essentially go back to our life. We will probably face future challenges. This is not my first epidemic. My first day in residency was with a young man who had a disease that was only subsequently identified as AIDS. We were able to, with a lot of healthcare effort, tame and manage that difficult illness. We will manage this one as well, and we want to be a partner with you in doing that, and we look forward to continuing to serve you.
Thank you, Dr. Murdy. Somebody's asking how we can, how you can get invited to future sessions, and you can email Natalie. Her email is coordinator@ltseniorservices.org, coordinator@ltseniorservices.org. We thank you so much for being here. We appreciate it. And thank you, Dr. Murdy. And we look forward to seeing everybody next week. Bye-bye.
Please don't hesitate to reach out through us through Baylor Scott White's app or call, and our staff will be happy to help you make sure that you can get connected to the care you need.
Thank you, Dr. Murdy. Bye, everyone.
Bye.
Natalie, you want to stop the recording?
Yes, I was just writing one thing down.
Okay. Thanks.
Great job, you guys.
Thank